Regarding ankle fractures, for evaluation of ankle fracture, you should take the pertinent history, mechanism, timing, soft tissue injury, bone quality, comorbidities, and associated injuries. On physical examination, you need to check the skin, nerve, vasculature, pain, and deformity, and to exclude compartmental syndrome. Look for subtle signs of soft tissue injury like skin tenting as well. Regarding the radiographic evaluation, it is quite important that the joint above and joint below are radiographed. Ankle series, that is AB lateral and mortise view, should be done. Special films like manual stress tests or gravity stress tests can be advised. A CT scan for specific pathology is advised. In an AP view, I need to check the tibiofibular overlap, which should be 10 millimeter. A tibiofibular clear space should be less than 5 millimeter. And on view of fibula can evaluate if the screws through the fibular plate are going to the incisura. A mortise view, in mortise view, the tibiofibular overlap should be more than 1 millimeter. Talocrural angle should be less than 8 or more than 15 degrees. In mortise view, it is taken in 10 to 15 degree of internal rotation, and medial articular surface in a tangent to the beam with posteromedial and posterolateral border of the talus visualized. Incisura line up with the lateral border of the talus. Medial articular surface of the talus perpendicular to the beam of the X-ray. Other image modalities can be a stress view, that can be a gravity or a manual or a weight-bearing mortise view. A CT scan is done for articular involvement and posterior wall characteristics. MRI for the ligaments or tendon injuries or talar dome lesions or syndesmotic injuries in certain special situations. Manual stress test is done to evaluate deltoid ligament. Foot is completely dorsiflex and apply external rotation force on foot with tibia being stabilized, and a radiograph is taken. The positive findings is incisura is medialized in compared to the lateral border of the talus. The second is that there is increased medial clear space widening. A lateral aspect of the foot is down in a gravity stress view. This is an alternative to manual stress view. A comparison between gravity stress view and manual stress view shows no difference in determination of deltoid ligament injury. A CT scan can change the mode of treatment in 25% of the cases, especially in trimedullary fractures. The emergency department management in open fractures should be IV antibiotic, betadine soak gauze over the wound, or a saline soak gauze. Intra-articular blocks compared with conscious sedation for close reductions were evaluated and show similar results. Regarding the classification, the most common classification easier is the Dennis-Weber classification. Type A is below plafond, type 2 is at the level of plafond, and type C is above plafond. Then is a Lag-Hansen classification. which classified into the following: a supination external rotation injury, that is stage 1 is anterior inferior tibiofibular ligament disruption, stage 2 is oblique fracture posterior superior to anterior inferior, grade 3 is posterior inferior tibiofibular ligament or posterior malleus fracture, and stage 4 is deltoid or medial malleus fracture. How to differentiate between supination external rotation stage 2 from stage 4. Determine the medial side stability, medial side tenderness, medial side swelling, and medial ecchymosis. Why does differentiating between supination external rotation stage 2 and stage 4 matters? Stage 4 ankle fractures, stress positive ankle fractures are indication to operative intervention. Decision tree. A fibular fracture associated with a stable ankle motice heals without significant functional consequences. The important is to keep the talus under the tibia. Fibular fracture associated with unstable ankle fracture motice heal with significant problems, assuming that this instability can cause talus shift. So whenever there is a fibular fracture, we need to do a weight-bearing views or a manual stress view to check for a medial clear space and confirm the medial involvement. Regarding this surgical treatment checklist, first you have to address the fibula, ensure adequate length is maintained using contralateral side or a dime sign. Anti-glide versus neutralization plate fixation and may require bridging fixation if it's comminuted. Posterior malleus, if present, consider fixation degree on depending on the size of the fracture. If it's involving more than 20 or 25%, needs fixation. Medial malleus fracture, if it's present, go for a fully threaded bicortical screws versus partially threaded screws. A stress ankle X-ray will help to assess the syndesmosis. A dime or a ball sign is a round recess comprised of distal tip of the fibula and lateral process of the talus. It is helpful in ensure the adequate length of fibula is achieved. For a medial malleus fracture, bicortically fully threaded lag screws had superior biomechanical, radiographic, and clinical outcomes compared to partially threaded lag screws in a study. This study was conducted by Ricky et al. In 2012. Regarding the medial malleus, it can be divided into 3 zones. Zone 1 is the anterior zone, Zone 2 is the middle zone, and Zone 3 is the posterior zone. Regarding assessing if it's impinging the posterior tibia tendons, Zone 1 does not contact with the posterior tibial tendons. Zone 2 on average 2 mm from the posterior tibial tendons. And zone 3 abuts or injured posterior tibial tendon in all specimens. This is the study conducted by John Femino. Regarding supination adduction injuries, there is a transverse Weber A or B distal fibula fracture, and stage 2 is a vertical medial malleus fracture. Often this is with the medial impaction and compression side failed. So the fibula is on the tension side and the medial malleus is on the compression side. The discussion regarding such fractures of medial malleus is whether to fix intramedullary screw versus plate. The stage 1 plate that is placed in anti-glide mode. Regarding the pronation external rotation injury, stage 1 is deltoid or medial malleus fracture. Stage 2 is anterior inferior tibiofibular ligament or interosseous membrane disruption. Stage 3 is a spiral Weber C fracture. And stage 4 is posterior inferior tibiofibular ligament disruption or posterior malleolar fracture. In these fractures, syndesmotic disruption is expected. A goal is to have fibular length and rotation achieved. Congruent ankle mortise along with syndesmotic stability with either posterior malleolar fixation or syndesmotic screw fixation. Pronation abduction has stage 1 transverse medial malleus fracture or deltoid ligament injury, posterior inferior tibiofibular ligament or posterior medial fracture, and stage 3 with a compression bending fracture of the fibula. In pronation abduction injury, medial malleus fracture should be fixed first. This drives stability, so always fix medial malleus first. Fibula comminuted and length stable construct should be achieved, and the syndesmosis should be tested with a stress view and fixation should be done. Regarding posterior malleus, stability prevents posterior translation of talus and enhances syndesmotic stability. This is the origin of posterior inferior tibiofibular ligament. Weight bearing increases surface area of the ankle joint. CT scan is quite helpful in certain situations. Classical indication of fixation is more than 25% of involvement of posterior articular surface. Then some indications is regarding the posterior malleolar fracture is posterior translation of the talus or syndesmotic widening. Fixation options can be screw fixation or a plate fixation. The screw, when fixation is we are doing, it should be anterior medial to posterolateral screw trajectory. Regarding syndesmotic injury, its function is to resist external rotation, axial lateral displacement of the talus. A weight bearing allows for standard loading. Consists of anterior inferior tibiofibular ligament, interosseous membrane, posterior inferior tibiofibular ligament, and inferior talar ligament. There is wide variation in the shape of incisora. How to determine if instability is present? First is doing a manual stress test. You can by doing external rotation and checking for the displacement of the tibia restrictor fibula. Then a cotton test can be done intraoperatively with ankle fracture. When should the manual stress test be performed? Following fixation of other indicated components and then check. It has been indicated by Hines et al. That using a clamp can lead to overcompression and leads to limited dorsiflexion. Whenever using a clamp, a medial tined placement along the tibia should be in the anterior 1/3 to decrease malreduction. Regarding the fixation, there is a study. You can use 3.5 mm versus 4.5 mm screws. 4.5 screws are more prominent. Regarding 1 versus 2 screws, 3, 4, 6, and 8 cortices. In 6 cortices, there is a windshield wiper phenomena without removal. In 8 cortices, there is a risk of screw breakage without removal. Regarding endobutton fixation or screw fixation for syndesmosis, there is no functional outcome difference. At 1 year follow-up of these ankle fractures, patients do well. There is a significant difference in functional recovery at 1 year compared to 6 years. Younger age, male sex, absence of diabetes, and low ASA predicts a good functional recovery at 1 year time. Patient-related adverse outcomes: advanced age, osteoporosis, diabetes mellitus, peripheral vascular disease, female sex, high ASA, smoking, alcohol use, and lower level of education. Regarding the ankle arthritis, osteoarthritis post-trauma is related to the fracture severity, complications, and older age. Regarding the complications, perioperative malreduction, integrated reduction, or intraarticular hardware penetration, early postoperative period, wound adjacence, necrosis, infection, compartmental syndrome, late stiffness, tibiofibular synostosis, malunion, non-union. A quick note on diabetic ankle fractures. The problem in them is their higher complication rate with wounds and fixation stability. Patients often lack protective sensations and poor bone quality. The solution is unstable ankle fractures are still best treated with anatomical restoration of the ankle motice and stable internal fixation. Continue to minimize soft tissue trauma. Double the fixation and non-weight bearing period in neuropathic patients. This is by Costigan in 2007. Regarding the post-operative care, the patient should be non-weight bearing for 12 weeks period.